All right, let's get on to the specific vaccines per se. Probably one of the first things that we talk about is because of the sense of contagiousness. Measles is highly contagious, and so there's periodically these outbreaks for measles, and we often see them these outbreaks in vulnerable populations who have not been vaccinated, where there is not herd immunity or may not be herd immunity for that cohort, and in large gathering places. So, 8, 10 years ago was a significant outbreak of measles in Disneyland, um, and really concerning. Uh, is for really anyone, someone who has measles that goes on an airplane, for example, or is in a contained area for a period of time, is a real risk for spreading measles. Now, you might think, well, measles is not that serious. Yes, it is. The concerns with outcomes with measles include, among other things, encephalitis and even fatalities. There are other long term complications that can happen as well with measles. So, measles is not something to just sort of say, oh, uh, we just can ignore it. And measles is an example of many of the vaccine preventable diseases that when people, it's been so effective, the vaccine over the last 50 years, that people forget what measles is like and what these vaccine preventable diseases can do and how significant they can be. And so they tend to think, oh, I don't need to get vaccinated because they don't remember what that's like. If you speak with someone who's lived through a period of time where these vaccine preventable diseases there was no vaccine for them, you'll pretty much get a sense of how important it is for vaccination. I also talk a bit about mumps and rubella here because the vaccine we look at is a three different, the vaccine for measles, mumps, and rubella is sort of usually bundled together as a single vaccine. Mumps can affect the parotid glands. They can also lead to meningitis, and in a lot of men, you can see orchitis and even sometimes infertility develop because of mumps. And rubella or German measles is, while it's usually mild, it can be disastrous for a woman who's pregnant. It can lead to miscarriage, it can lead to congenital defects, and so rubella is particularly dangerous for women who are childbearing, anyone who's childbearing and has a concern for fetal development. Because this is going to be a live vaccine, we are going to avoid giving this vaccine even though it's a live attenuated, meaning weakened vaccine. We still don't give it in a woman who's pregnant particularly because of the rubella risk. So the measles, mumps, and rubella vaccine, composed of 3 live viruses, it's very effective at producing antibodies and effective in almost 100% of patients, 97% within 2 to 6 weeks. Uh, what you'd expect to see for side effects with this and most other vaccines is some mild soreness at the injection site, maybe some glandular swelling occasionally, although usually not significant. Occasionally a rash, but quite rare that anything severe can happen with measles, mumps, rubella. The big concern, though, is pregnant or women or anybody who's childbearing of childbearing age. Or you might be a little more concerned if a patient had a history of thrombocytopenia or anaphylactic reactions. We want to be careful about those. And if we typically will, for many vaccines, if individuals received immunoglobulins in the prior 3 to 6 months, we often will consider avoiding the vaccine. That's specific on the particular vaccine, so you have to be careful about that. But if somebody's gotten immunoglobulins in the last 3 to 6 months, the vaccine may not be quite as effective. And so you want to be aware of that. And we are avoiding it and contraindicated again in individuals who are pregnant, but also individuals who are severely immunocompromised or have immunodeficiency of any kind. So here's where it lands in the pediatric schedule. It is usually dosed at about 12 to 18 months and then repeated again at 4 to 6 years of age. If you go to the CDC's website, typically the charts, they give you lots of specific information. Here's the detail about the 2-series vaccine given at age 12 to 15 months and again age 4 to 6 years, and catch-up vaccination if it's indicated, and then any special circumstances with the vaccine. Measles, mumps, rubella also recommended for any individual born in or after 1957. Prior to 1957, most individuals probably had direct exposure to measles in their childhood because it's so very contagious. And so most of those individuals will have had immunity. But it's not so clear from 1957 on if somebody had exposure to measles and has immunity to it. And so recommended giving measles, mumps, rubella vaccine in that cohort. And the only individuals for whom we have it contraindicated are anyone who could be pregnant. So you absolutely want to do a history of could this individual be pregnant and and then do a pregnancy test before you give it in anyone of childbearing age and could be appropriate. And also for folks who are severely immunocompromised, because remember, it's a live vaccine. These specific guidelines are also listed in the table for adults. Again, where it fits, patients born after the age of after 1957, meaning patients 65 or younger, are candidates for this vaccine. And then there are special circumstances. Again, we talk about pregnancy and immunocompromised status of being important. Okay, another set of conditions is diphtheria, tetanus, and pertussis or whooping cough. Another three element or three constituent of either 2 or 3 elements in the vaccine. Diphtheria related to Conibacterium diphtheriae can cause significant epiglottal swelling, impede swallowing and breathing. And while it's rare to see, it was not uncommon, to see it in the before 1980, and even since 1980 to 1992 have been cases reported. Tetanus or lockjaw, frequently fatal, and it's because of because of the toxin that's produced in tetanus. And I will tell you quite honestly, we had a patient in our ICU within the last 4 or 5 years who had tetanus and had to be put on a ventilator because of the skeletal muscle concerns that there were for this patient who affected respiration. So don't underestimate tetanus and the importance of getting vaccine for that. And finally, highly contagious is pertussis or whooping cough. And particularly, this is a concern for newborn infants and young children who have not yet been vaccinated. We can treat it with macrolides or sometimes cotrimoxazole, trimethoprim sulfamethoxazole. We sometimes do that, but it's better to prevent it, particularly in young children and infants and newborns who can't get the vaccine. So the people around them, parents, child care workers, particularly grandparents, anybody's around children, the more we have this pertussis vaccination status, the better is the herd immunity that protects these young infants. But we occasionally have outbreaks of pertussis and whooping cough. I can think of in our region in New England, we've had a couple of outbreaks of pertussis maybe every 4 or 5 years, and you hear about it, and it's preventable. It's vaccine preventable. So we have a couple of different vaccine options here. We have a diphtheria, a tetanus toxoid. A toxoid is it stimulates immune response against the toxin for tetanus, not tetanus itself. So that's what we mean when we call a toxoid. But we have a vaccine for diphtheria, and we have a vaccine for pertussis. The vaccine that's been available for the last decade is the vaccine for acellular pertussis. Meaning it is a more refined vaccine. The earlier vaccine that was available for pertussis more than a decade ago had a fair amount of adverse effects associated with it, more muscle arm aches, and the vaccine was pretty much refined with using only a component of the pertussis that has rendered it a much better tolerated vaccine. So patients may share with you, oh, they had that years ago and they had a problem with it. And, one of the concerns that patients will raise is, I'm not going to get it again because I'm quote unquote allergic to it. But the newer acellular version is much less likely to cause any particular problems. You want to get to the root of what that problem is. So the reactions generally pretty well tolerated. I can tell you that the more severe reactions that happened a decade or two ago, when the older pertussis was available, were more problematic, but pretty well tolerated vaccine. In pediatrics, we look at starting the series for it at 2 months. It's one of the earliest ones that we start, and then we repeat them with a series of multiple vaccines over time, including into adulthood. So the routine 5-dose series in pediatrics is at 2, 4, 6 months, 15 to 18 months, and then 4 to 6 years. And then we look at, there's a catch-up process for that. And we look at in wounds, we particularly worry about tetanus in wounds. And so we will look at giving in pediatrics less than the age of 7 with a history of 3 or more doses. They're talking about whether or not you give a repeat dose or not, depending on the window of time they've had since their last vaccine and what the nature of their exposure or wound was. Could it have been, or what we classic sort of stereotypical issue is a rusty nail or something they stepped on. We also use this vaccine in adults. The recommendation is that you want to give the next time the person is ready for their booster, which should be about every 10 years for a tetanus diphtheria, that the first dose we usually give is the tetanus diphtheria with the acellular pertussis in it. And then subsequent doses after that are may or may not be the tetanus and diphtheria alone. So we always want to make sure, though, that if they hadn't been protected for pertussis, that they received the acellular pertussis as a component. Otherwise, they could use just the if they've had one in the last 10 years, they might just be candidate just for the plain tetanus and diphtheria. But it probably doesn't do them any harm to get a booster for the tetanus, diphtheria, and acellular pertussis every 10 years anyway. Finally, contraindications really, unless it's been some major issue, not a lot of major contraindications to this vaccine. Pretty well tolerated, even in women who are pregnant or could become pregnant. Okay. The specifics here for routine vaccination after the age of 11 years is a single Tdap dose, and then either the plain tetanus diphtheria or the tetanus diphtheria with acellular pertussis again every 10 years thereafter. You do want to look at the wound management criteria, though, that folks, you sometimes look at significant wounds that you might actually give it 5 years after the last dose. So if you're dealing with wound management, wherever you are, one of the questions is going to be, when's the last time you had a tetanus shot or tetanus diphtheria acellular pertussis vaccine? And if it's a significant wound and it's been 5 years, we often recommend the repeat dose of that. Okay. Let's go on to polio. Polio can lead to skeletal paralysis of the legs, and particularly, but when it happens, it can be fatalities can be up to 10%. No cure. The treatment is variable depending on how incapacitated patients are. And we pretty much are considered to have been eliminated in the Western Hemisphere. But in fact, what we've seen is a resurgence worldwide in the last decade or so of polio, and it's a real concern for folks. Now, there's a lot of history of polio and the polio vaccine, and anyone who's sort of interested in the topic of polio in the 1950s, it certainly was a concern for the 1940s and 1950s. One of our former presidents, Franklin Delano Roosevelt, had polio, had some, certainly some incapacitation secondary to polio, and how it manifests for him. And by the mid 1950s, there was real concern about the spread of polio. And I'm old enough to have remembered somebody in my neighborhood who was forever, had to wear braces and walk with crutches because of polio. And so it kind of struck us that it hit home pretty much for us. But people who don't have those kind of experiences or memories tend to kind of poo-poo the vaccine. Hey, I don't really need it, because they don't really remember the impact that these vaccine preventable diseases had. There are two forms that historically have been available, the oral polio vaccine and the inactivated polio vaccine, the Salk vaccine. The oral polio is a live vaccine, and we really don't use that oral polio anymore. It's pretty much the inactivated polio virus vaccine. But the oral polio vaccine may have been used in other parts of the world, and they may have been administered earlier in someone's life. And so you'd probably want to recognize that there were two forms, even though now it's pretty much the inactivated form. The adverse effects typically are well tolerated, although the older oral polio, that's a live virus a vaccine that we don't really use anymore, live attenuated, we don't want to give those to folks who are immunocompromised. And typically it's really pretty much the inactivated polio vaccine we use. The criteria in pediatrics and when they're kind of are listed on this chart. You can see kind of early in life, 2 months, 4 months, 6 months, and a booster at 4 to 6 years. You'll see the routine vaccination guidelines again listed here, and an option for catch-up. And then, some issues that around the oral polio vaccine, which people don't really use to any extent, but were administered before 2016. In adults, we don't really have a guideline for giving polio vaccine. It's usually a childhood vaccine, and there's no specific listing for contraindications, partly because it is primarily a pediatric vaccine. Next, let's talk about Haemophilus influenza. Now, this is the bacteria Haemophilus influenza, not influenza, the virus, okay? So Haemophilus influenza type B, a bacteria that can cause meningitis, pneumonia, and serious upper respiratory infections, including ear infections and serious sore throat. And it can lead to really serious illnesses, particularly meningitis, under the age of 5. And those cases of meningitis will often have long-lasting sequelae and up to a 5% mortality. I mean, it's pretty awful. I will tell you that this vaccine has rendered, for those who take it, the issue of meningitis, which H-flu meningitis was about a third of the cases we saw in pediatrics, that's almost, I won't say it's unheard of now, but it is much, much less problematic now. In addition, Haemophilus influenza is one of the pathogens for bacterial ear infections, and patients who get this vaccine will have a lower risk for otitis media ear infection. So really quite an effective vaccine. The conjugate vaccine that's been available now for a couple of decades at least is pretty effective, and its adverse effects are almost I won't say non-existent, but of all the vaccines we have, probably the best tolerated, the least problematic of them. We see that we start giving the Haemophilus influenza vaccine series at 2 months of age, with the series listed here. And the criteria and issues at series, again, the 4-dose series at 2, 4, 6 months, and 12 to 15 months of age. There are other sort of variants depending on the vaccine that's available. But there's a 3-dose. One brand is a 3-dose series as opposed to a 4-dose series. There's catch-up criteria. Then there's sort of special considerations for patients who are undergoing chemotherapy, for folks who have had stem cell transplants, and other sort of concerns, whether a patient is asplenic or not. So you can kind of see through in their degree of immunodeficiency, which who are candidates or not candidates under those special circumstances. The Haemophilus influenza vaccine is listed in adults, and it's pretty much specific to the individual patient and their risk factors, as well as whether or not they may have received this in the past in their earlier life, although this vaccine was not available probably for people who are now, over the age of 45 or 50. And the contraindications, pretty much no major contraindications, but a couple of subsets of patients who may or may not be candidates for this under certain circumstances. So the special circumstances pretty much for H-flu are folks who are asplenic. And these folks are candidates for it, as well as folks who have had stem cell transplants. Again, are candidates for this, even if they've had some of these folks, even if they've had Haemophilus influenza type B vaccination prior in their lifetime. Let's talk about varicella or chickenpox. Varicella, highly contagious, potentially dangerous, particularly for folks who are immunocompromised. It's caused by the varicella zoster virus. It's a herpes type virus. And you can see many folks who have varicella exposure and go on to develop varicella or chickenpox may have secondary bacterial infections that happen. This is true for many viral infections that become secondarily a bacterial infection. And they also can cause some central nervous system complications. That's really problematic. The presentation of varicella is more severe as patients get older into adulthood. And then a lot of individuals who have had varicella as a child have a risk for herpes zoster later in life or shingles. So varicella, important vaccine to look at utilizing whenever we can. The downside to the varicella vaccine is it's one of the live attenuated vaccines. And so we have a subset of patients who can't get the varicella virus, particularly those who are immunocompromised, might be pregnant. And so it is all the more important that those who are capable of getting it receive it for adequate herd immunity to protect those individuals who can't get it and for whom their immunocompromised status poses a risk if they were to get varicella exposures. So highly effective, pretty well tolerated. And then if folks who get the vaccine, if they get a varicella outbreak in the future, it's usually quite mild. The adverse effects for the vaccine, even though it's a live vaccine, it's pretty well tolerated. There is, you expect to get soreness, swelling at the injection site. That's pretty common for many vaccines. Sometimes you get a little bit of a fever, the kind of thing that indicates you've got an immune response developed. We don't want to give it during pregnancy. We don't want to give it to folks who are immunocompromised. And we don't want to give aspirin or the salicylates for up to a period of 6 weeks because of the risk potential for Reye syndrome in pediatrics. We'll talk more about that later in the year in pediatrics. The vaccine typically given subcutaneously. It's pretty cost effective in how its use. Here is the timetable of the window. It's really 12 months and a repeat dose at age 4 to 6 years. The routine vaccination, again, the series for most everybody, it fits in this window of time. There's a catch-up approach as well. If folks are older and haven't received the vaccine, there's the option to take it again. For adults, the varicella vaccine is recommended for folks who were born in 1990 or later, particularly if they haven't had their varicella vaccine earlier in life, but it is contraindicated in patients who are pregnant or immunocompromised. So the varicella vaccine, you typically look in adults for a 2-dose series, 4 to 8 weeks apart, if they did not receive varicella vaccine earlier as children. And then there's other sort of guidelines and special circumstances here, avoiding in pregnancy and individuals who are immunocompromised. Another vaccine is for herpes zoster, for folks who have had the risk, particularly older folks who have had the risk for varicella exposure in childhood, which is a lot of folks, over the age of uh, uh, 30 or so have never gotten the vaccine. And for those, it's indicated for those patients who are over the age of 50. Typically, we think of it as in a sense, a booster, in a sense, to the varicella exposure earlier in life, where with the vaccine, you develop enough titers or immunoglobulins to fight the varicella that can present as shingles. Really a highly effective vaccine. It's not indicated in pediatrics, only primarily for patients over the age of uh, 50, excuse me. But as we look in adults, it's over the age of 50, but there's new guidelines now for immunocompromised patients who are younger than the age of 50, and that's fairly new for this vaccine. And so you will see for folks who are immunocompromised, herpes zoster, varicella shingles vaccine indicated below the age of 50 in this cohort. And that's a fairly new recommendation from the CDC. Vaccine is highly effective. It's typically not big contraindications to use over the age of 19 when you're immunocompromised, and over the age of 50 for everybody else. And there are some guidelines and recommendations. What's really rewarding about this vaccine, it got approved in 2017, so fairly new on the vaccine horizon availability. And there was an earlier live attenuated herpes zoster vaccine that was not nearly as effective as this 2 vaccine series is. And this vaccine pretty well tolerated as well. So important to consider what disease prevention we're seeing. Herpes zoster or shingles used to be sort of quite widespread until this vaccine is available. Now it is almost preventable. And when it happens, it would be usually a very mild case of herpes zoster or shingles. But if you've known anybody who's had shingles or herpes zoster, painful. If it involves the facial area and gets in the eye, it can lead to blindness as well. It can be really quite debilitating. So this vaccine is really quite a wonder. Hepatitis B vaccine. Hepatitis B, we don't have a lot of great treatments for Hep B. And the risk for Hep B is severe liver complications and liver failure. So the vaccine is really a boon to prevent Hep B. Again, a very significant disease. The hepatitis B vaccine is quite effective in its use, and about 85% of folks get some degree of protection after the second dose, and about 90% after the third dose, even more than that. And it lasts for at least 5 to 7 years, but I think in this day and age, we really think it probably lasts well beyond that because we don't really recommend boosters for it. Adverse effects are pretty minimal. It's considered one of the safest vaccines to use. However, we want to make sure that the site of administration is appropriate. Early, when this vaccine was available in the early 1980s, there was injected in the gluteus, did not have as effective a response as we saw in the deltoid. And some of that probably has to do with, for any vaccines, and this is one example, is you want to pay attention to the needle size and recommendations for somebody who might have a lot of adipose tissue, for example, and what's the efficacy of the vaccine in part may relate to how it's administered. So is it the correct size needle? Is the bore of the needle appropriate? Is the site of injection appropriate? If it's depending on where it's intended to go, is it an IM or a sub-Q? Sub-Q is pretty easy, but IM injections for vaccines, the route of administration and how deep it gets into intramuscular tissue can affect efficacy. So an important consideration when you're looking at vaccines. For pediatrics, this is the very first vaccine out of the chute. It is given usually within 24 hours of birth, sometimes within a couple of hours for a full-term infant. So, and then the second dose is given within the first couple of months, and the third dose is given from 6 months onward. And highly effective and highly safe vaccine. There's lots of specific recommendations. There are different versions of hepatitis B vaccine. And so if you happen to be in a particular practice area, you'll find that the pediatric vaccine, the neonatal vaccine, might be different than the adult vaccines that are available. So you'd want to pay a little attention to that. But clinically, the Hep B vaccine in childhood is routine and given sort of first out of the gate. In adults, Hep B vaccine depends on the vaccine status of the patient. You as a healthcare worker, most of these vaccines, they're going to be a requirement of your employment where you work. Hep B, you probably all have been, or most of you, I hope, have been vaccinated with it. Most folks develop titers, a couple of folks don't. And you want to just be careful about knowing if you've responded to Hep B or not if you're working in healthcare where you could be exposed by an inadvertent needle stick or something like that. There are really no contraindications to Hep B vaccine. And the adults, there are circumstances here for what the recommendations for the dosing series are. And depending on the agent you're using in the formulation, they may recommend a 3 or a 4 dose series depending on where you are and what your status is. Okay. Hepatitis A. Hep A is serious. Not we don't usually think of Hep A as producing the long-term liver failure risks that Hep B and Hep C could. But Hep A is serious, and particularly folks who have pre-existing liver disease, even more so. It's a oral fecal route of transmission, so you want to be kind of careful of that. The vaccine's been around for a fair long time. I mean, a couple of decades, and it's pretty effective. Really, it's a childhood vaccine, but also widely used in adults, and it's often a shared decision making in adults about who gets it and not. But it's a 2-dose series. In pediatrics, it's typically started at about 12 months. And the 2-dose series are 12 and 23 months, two doses within that window of time typically, but a catch-up approach. You also want to think about individuals who are traveling in areas where Hep A could be endemic. So those areas, be thinking about any place, anywhere in the world, including the United States, where there might be an impact for sewage systems that are compromised. Certainly, I think of this in folks who are responding to disasters, hurricanes, for example, where sewage systems are compromised. Then the risk for Hep A is much greater in folks who are treading through contaminated, flooded water areas or floods where those systems are compromised. So you want to be really careful about sort of those circumstances, or any place where hygiene. The Hep A dosing series for adults, in a sense, I guess, as we alluded to before, is based on some shared decision making. Really no major contraindications, but considerations for use. And this, really, anybody could be a candidate for Hep A vaccination. And typically, even if folks are not necessarily at high risk, but want to be protected against Hep A, go for it. Okay. The special circumstances where I think we do see folks who should be vaccinated against Hep A are folks who have a history of chronic liver disease, folks who have immunocompromised status, HIV infection particularly, folks who do injectable drug use, men who have sex with men, and anybody who is at risk for oral fecal transmission risk, or who works in an area where there's a concern for that. So all of those are considerations that should be uh, under evaluated in a patient evaluating their risk and benefit for Hep A. Pneumococcal infection. The pneumococcal vaccine series is a little complicated in the last couple of decades, and sequencing and different products that are available. So let's try to map this out and think about the options that we have. The pneumococcal infections itself, this bacterial infection, can lead again to meningitis, as we saw with Haemophilus influenza type B. And pneumonia risk, as well as otitis media. So pneumococcal vaccine in childhood can lower the risk for meningitis, significant, very significant, lower the risk for otitis media, pretty common infection in pediatrics, and also for pneumonia risk, which is less common in pediatrics, but still a risk. The conjugate form of the vaccine was approved for the last 20 plus years, and it would be estimated that between 85 and 90% of patients will respond quite dramatically to this vaccine. So the pneumococcal conjugate vaccine, sometimes referred to as PCV13 because of the 13 valences that are sort of covered by this. We sometimes forget when a vaccine comes to market what is sort of related to what kind of outcomes that can be seen with giving it. But it was pretty clear that when this vaccine first became available, we saw a dramatic drop in invasive pneumococcal cases, quite significantly. This is an old study, of course, but it reminds us the importance and the impact that these vaccines can have. And so important to consider that. Pneumococcal infections, again, we really worry about strep pneumo for meningitis, for otitis media, which is usually less invasive than meningitis, which is very invasive. But you want to be careful about considering making sure folks are adequately vaccinated. So the data we see here, we see many fewer, significantly fewer issues with otitis media. The numbers don't seem as great, but that's pretty significant data to have a vaccine that has this impact. The vaccines for adults, though, have gone through some conversions in the last 8 to 12 months. And so the pneumococcal vaccine series has changed. There are really 4 different products. There's conjugate vaccine 13, 15, and 20, and there's a polysaccharide vaccine 23. In these vaccines, it's a bit confusing when you stop and think about where they each fit, particularly in this conversion window of time. The pneumococcal vaccine 20 is the latest on the block, the conjugate vaccine PCV20 for adults, typically indicated for patients who are over the age of 65, or if they're immunocompromised or have medical conditions that pose risks for them. Ages 19 through 64 are candidates as well. So there's some sequencing issues with some of the older products, but when we go to the tables, it'll be a little more clear. And so don't worry too much about these sequencing issues. In fact, these sequencing issues are becoming more of a question in the transition of folks who have received the prior pneumococcal vaccine. If it's their first pneumococcal vaccine, we're typically, it's pretty straightforward what we do. As you look at that, the timing on what the recommendations are for the CDC is for adults is everyone over the age of 65 should get protected against pneumococcal infections. And then between the age of 19 and 64, folks who have these other risk factors that pose some degree of immunocompromised states. The big issues I think we think of here is anything that leads to the potential for immunocompromised status, or folks who have had particular implants or other kind of risks for pneumococcal infection are candidates. There are all of these 4 different pneumococcal vaccines available, and so it's kind of confusing who gets what. But most of the time, you're, in adults, if they're getting the brand new PCV20 vaccine, they get it once, they're done. Okay. If they've used a PCV15 in the past, which we're not really starting folks on much anymore, then we'll give them the PCV23 thereafter. If they've gotten the 23, then we give them either the 15 or the 20 after. Those are kind of, it's confusing in this transition, but you kind of want to go to the website or to the app to kind of navigate this for folks who've already gotten a certain pneumococcal vaccine. Here's more tables that recommend folks who have never received the pneumococcal vaccine. Almost everybody is a candidate for the conjugate 20 vaccine, and these are sort of criteria based on age. Who's a candidate for which individuals are candidates? Again, most folks are probably going to go with the PCV20 conjugate vaccine, or they could get a 15 followed by a 23 a year later. The old 15 has largely replaced the older 13 in adults. So again, there's more sort of, if you've gotten the 13, then what do they do? How do they sequence it? There's lots of tables here for that, but don't fret about this too much. Similarly, the folks who've had the 23 and what to do, again, don't fret about it too much. So the bottom line here is, what are the formulations that are here in pediatrics? The pediatric dose is the 13, the conjugate 13 for the most part. And what you'll see is there's a series that start at 2 months, 4 months, 6 months, and then 12 months. Now, what's not clear to me is over the next couple of years, if the conjugate 13 vaccine recommendations may change over time. So, the 13 versus the 15 versus the 20, you may see things change over the next couple of years as there's more experience with these different pneumococcal vaccines, particularly because the 20 is the latest coming out of the block that came out in early 2022. So you'd be aware of that these may change. But right now, with the latest updates from the CDC as of the fall of 2022, is still looking at the PCV13 in pediatrics. The criteria again are 2, 4, 6, and again 12 to 15 months with a catch-up, and then special circumstances, particularly folks who have immunocompromised status, sickle cell, cochlear transplants, lots of other sort of specific issues. For adults, pretty much for the new starts, it's PVC20, or they could get a PVC15 followed by a 23. That's still in the guidelines. It may stay. And then you can find, again, the criteria for those under the age of 65 if they have other compelling indications. They're really pretty well tolerated. There's not a lot of serious consequences associated with the pneumococcal vaccine, so there are not a lot of contraindications. It, again, is not a live vaccine. And then the recommendations, again, adults, PCV20 is the standard approach. And then if they've received already a pneumococcal vaccine, then they may sequence into some of those as well. Okay, on to influenza. Influenza, the issue for the vaccine and what are the elements or constitution of those vaccines, the available vaccine products, they change every influenza season. And so each year the CDC works with the World Health Organization and local and regional, national, and international public health departments to try to sort of evaluate what are the likely influenza pathogens for the upcoming season, and then will render a vaccine, usually kind of pinpointing what the valence is or what the specific elements of those vaccines are, the composition of those vaccines are going to be. And so usually at the beginning of influenza season, it's really helpful to go to the CDC's website and go to their FAQ section. And they really do a nice job of summarizing what the differences are for that influenza year. So here on this one page, you could just go to that and you could see, okay, what's the composition of it? You could see what are the available formulations that are available for patients over the age of 65. Is there any recommendations that are similar or different from the prior influenza season? What are the ages? What are the available products for the year? Um, if things changed or not. So you'll sort of see that things subtly change, sometimes dramatically change from influenza season to influenza season. The other things you'll find about the influenza vaccines are, can they be given concurrently with another vaccine? Particularly in fall of 2022, the big question has been, can I get the flu vaccine with the COVID vaccine or booster? And yes, you can. I think that some clinicians, the recommendation for giving them both at the same time is you have a captive audience. You have a patient who's there, just get it done with. Do both of them at the same time. There's a little downside to that. The downside to that is that if you have an adverse effect, well, which vaccine caused it? And so that's not always ideal, but usually both the COVID vaccine and the influenza vaccines are pretty well tolerated vaccines for the most part. Folks who've had the COVID vaccine, you certainly, I think, are aware that sometimes you get that scenario of the immune response initially, and sometimes that's seen with the newer bivalent COVID vaccine we see as well. But it can be given both at the same time, and in fact, that's often encouraged, particularly for folks who otherwise may not come back for their flu vaccine or their COVID vaccine. So again, look at what's available. Adverse reactions, there are folks with the flu vaccine who will have the same kind of usually milder reactions that you might see with the COVID vaccine. So people get that immune kind of response, but they're not infected with influenza. It's not, unless they're using maybe the live attenuated version, that's a different story. And we'll talk about that in a moment. But for the most part, even the inactivated influenza vaccine doesn't cause the flu and you still may get that kind of I feel lousy the next day. Okay. For pediatrics, you could use, and most people recommend, the injectable inactivated influenza vaccine. You can use, for a subset of patients who are in the appropriate age group, the uh, live attenuated nasal vaccine, the influenza mist vaccine. That's really only when you can't convince somebody to get in the injectable form. And the problem with the live attenuated is that it can actually have more risk for causing, a prodrome after, or a syndrome after the vaccine that looks more like influenza. And even though it's attenuated or weakened, if that individual is seeing immunocompromised or living with or around immunocompromised folks, those immunocompromised folks, there can be some viral shedding from that and potentially cause an issue. So the criteria typically are, for the influenza vaccination, children above the age of 6 months are candidates, and you can do, either of them. But for the most part, the recommendations are for those aged 6 months to 8 years, that they may be candidates for more than a single dose. Virtually everybody else is fine with a single dose once you get above the age of 9, but this is a fairly new recommendation about a second dose or a follow-up dose for influenza. The other issues you got to think about with influenza vaccination are egg allergies. There is formulation that's available for folks who do have an egg allergy, so there's an option there. You want to check for allergy status. And a lot of vaccines are sort of prepared with egg, depending on the nature of it. And so you want to read, if anybody does have an egg allergy for any vaccine, you want to pay attention to that and confirm the formulation you've got is not a problem with those allergies in their history. For adults, again, you could use the live attenuated. We typically don't for folks who are immunocompromised or pregnant, and we usually try to steer folks to the inactivated uh, injectable form. And then for adults, is typically once yearly. For folks over the age of 65, we usually try to go with a more effective, higher dose in those over the age of 65. And then the live attenuated version, the nasal, is contraindicated or precaution for folks who have some degree of immunocompromised status or work with folks or live with folks who are immunocompromised. So we generally try to steer away from again, the live attenuated nasal form. The routine, everybody gets an annual. We should really encourage it. We have, a whole wealth of experience with influenza vaccination. In many places in healthcare workers, it's pretty much a requirement or virtually a requirement for influenza vaccination if you're going to work in a healthcare setting around patients. So it's the right thing to do, as well as really offering good, not perfect, but good protection against influenza. Each year, the benefit of influenza vaccine varies based on did the CDC get the right cohort of quadrivalent choice in which valences they got of to compare to in the vaccine compared to what's circulating. They don't always hit it perfectly, but for the most part, it does a quite good job at reducing severity and even the presence of influenza. And the other thing with influenza to think about is the issue often for many patients in the mortalities associated with influenza might be the influenza itself. But as we see with other viral infections, particularly respiratory viral infections, you often have a secondary bacterial infection a week or two later. We often see bacterial pneumonias for patients who have had a first bout of influenza to start with, and those pneumonias can be fatal. So, again, influenza, there's fatalities associated with it. You really want to be careful and be aware of those risks. Onto human papillomavirus. This vaccine, when it became available, was just dramatic. It is really the first vaccine that we have available that can reduce cancer risk dramatically. We think about both cervical cancers and colorectal cancers. And so this vaccine is really highly touted and effective. And we look at it typically uh, in the uh, in the scenario of overall health status, both in pediatrics and in adults. In pediatrics, the window of time recommendation typically is age 11 or 12 years, but you can start even sooner than that at 9 years of age, uh, and then go through the sort of the recommendations for where it's used. The criteria here are listed for routine and also catch-up options for individuals who have had interrupted uh, situations. And then even in circumstances where folks who are immunocompromised, there's clearly a role for this. For adults, again, it's a 2 to 3 dose series depending on their age and their vaccine status. It's considered a shared decision making for ages 27 to 45. Uh, I I think that a lot of clinicians think that basically this should be open to anybody as a shared decision making beyond the age of 45, because primarily human papilloma HPV is a sexually transmitted, primarily sexually transmitted issue that poses a risk for cancers of all kinds. So, and I think a lot of clinicians would think even beyond the age of 45, it's kind of an arbitrary cutoff. But that's what the CDC says, and so that's what clinicians typically will sort of look toward. Okay. The issue I think that's helpful to sort of dissect is to kind of be matter of fact about the vaccine. When you talk with folks, be clear about it. There are, adults can choose their own decision making about whether or not they want the vaccine. It gets sometimes a little more touchy in circumstances where there are some parents who will have strong opinions about this vaccine because HPV is sexually transmitted, and gee, my child, won't be sexually active before marriage, and so I'm not worried about this. But we should be. We should always sort of advocate for what is in the best interest of that individual. But you may find that that becomes sometimes an issue. We usually, as most clinicians I work with, don't make too much of an issue about that and just kind of say this is they're up for these vaccines. Are you okay with this? Can we move forward or not? And not try to hide things from patients. Obviously, you want to maintain trust, but not sort of overplay that concern that parents may have. The contraindications for HPV vaccine, other than in pregnancy, is generally pretty well tolerated, and the benefit of preventing cancers is significant. So the criteria for routine vaccination, shared decision making, and special circumstances are also part of shared decision making issues as well. Another vaccine is the rotavirus vaccine. Rotavirus is typically a big concern in young children, less a concern in older children and adults. So this oral and live 5-valent vaccine is typically given pretty early in the vaccine series. And there was, more than a decade ago, a version of the rotavirus that was problematic with toxic side effects that have not really been seen with this version. So you might hear people be a little squawky about it, but for the most part, it's this version is pretty well tolerated. It's sequenced early again as a 3-dose series. It is started at, depending on the formulation, it's either a 2 or 3 dose at 2 and 4 or 2, 4, and 6 months. It's not an adult vaccine, so it doesn't show up on the adult tables, and again, doesn't show up on the adult contraindication tables. Meningococcal vaccine is really significant for certain types of infections, particularly certain types of meningitis, Neisseria meningitidis, and so important to consider where these fit. Like the pneumococcal vaccines, though, there are a couple of different formulations of the meningococcal vaccine that can sometimes get a little confusing about which vaccine and which cohort for the person in front of me. In pediatrics, there's specific criteria for meningococcal vaccine in early puberty and again a little bit later on. And then there's even an early adulthood in 18, 19-year-olds up to early 20s, another version as well. And we'll talk about those in a bit. So in pediatrics, the routine 2-dose series at 11 and 12 years and then 16 years of age for one of these vaccines. And you want to kind of pay attention to which one. There's certain dosing recommendations specific for the specific meningococcal vaccine that you see. And so you'd want to make sure that those are sort of at the appropriate time. So the routine series, again, some of these can be given if you look at sort of the criteria for giving to younger patients who have significant special circumstances. It might be sort of considered at those age groups, but the routine vaccination is usually wait until age 11 or 12 for most other individuals. And then some shared decision making from the age of 16 to 23 for the meningococcal serogroup B vaccination, which is different than the earlier one we just spoke of, and special circumstances for who's a candidate for that. In the adult, again, the circumstances are related to comorbid states, exposures, age, typically 9 through 23 for the meningococcal B after they've received the earlier meningitis vaccines are considered, particularly folks who are more likely to live in congregate housing. So that, classically included, college dormitories, school dormitories, military kind of circumstances, where that might be, the exposures might be greater. But that's not, just limited to those circumstances, and that's in a sense almost an artificial consideration. The specific meningococcal vaccines are sort of, you weigh the situation. Immunocompromised patients, you kind of weigh the risk and the benefit of that. Again, in pregnancy, weighing the risk and the benefit of that, we're a little cautious about some of those. And then the criteria for each of those vaccines and who gets them and when. Again, you kind of want to sort of look at this. This is an example. A meningococcal vaccine, I think, is an example of why the app on your cellular device or your mobile device is really helpful in navigating. I think for both the pneumococcal vaccine and the meningococcal vaccine, how old is this person? What are their comorbidities? Which formulation do I give? When do I give it? They vary a lot, and these apps really can help you when you're in the midst of things to remember where they are and how they're given. All right, one of the last sort of vaccines we'll talk about here that are on the schedules is a pediatric dengue vaccine. And this is really a consideration only in an older child who is living in an area where this is endemic. And so as you kind of see it, the areas really are not in the lower 48 or Alaska, Hawaii per se, but are in Puerto Rico and some of these other areas where it's endemic. And you could also go to the CDC's website or the World Health Organization website to kind of determine what the risk is for the patient that's in front of you. But because this shows up on the pediatric schedule, I have no experience with this vaccine, but you want to kind of consider between ages 9 and 16, is this person a candidate for this vaccine? And again, it kind of shows up there, not showing up in the adult cohort, not again in the adult. Okay, there are a lot of other vaccines that aren't officially on the schedules, and you want to be aware of these, and this doesn't even list all of them. But these are the vaccines that you might go to the CDC's website. You might have a patient who is a candidate for these. There might be a candidate because there's an outbreak, or they might be, COVID particularly. They might be candidate because they are traveling to a particular endemic area or a concerned area where this is a concern. They might be, so that might be true for Ebola. That might be true for typhoid or yellow fever, something like that. And those are often managed by a travel clinic. Or they might be occupationally at risk, for example, rabies, where the rabies vaccine, or they might have had an exposure where the rabies vaccine also makes sense. So I'm not going into depth there. I'm going to only talk about a couple of these here. And the rest of them, I kind of refer to you to go to the website, the CDC's website, to know about where they fit. For example, rabies vaccine. We don't routinely give it, but someone who works as a vet or a veterinary technician or animal handler of some kind that would be at risk for rabies might be a good candidate to receive the vaccine. And the vaccine is often used post-exposure to rabies in addition with the immunoglobulin, depending on the risk provider. And we see that a lot in emergency rooms. So if you happen to work in emergency medicine, you want to get up to speed on the rabies vaccine, immunoglobulin, and exposure risks. So you'll probably see that at least once in your emergency room rotations in your clinical year. Okay. But let's kind of go through a couple of things here, really focusing on really COVID vaccine. And I'm going to sort of focus in a little on the variant of smallpox vaccine, monkeypox, because that's kind of raised some concerns with an endemic in around the world in the United States. So the COVID vaccine is all, every week it seems like there's something different about COVID management, although it's kind of settled out a bit. And there are different vaccines, but I encourage you to go to whatever the latest CDC's website's information is. So as of early October 2022, the CDC just published in late September of 2022 this updated chart for the COVID vaccine. And they list, what they'll find is who's a candidate for which vaccine. Almost everybody's using the mRNA vaccine. I don't really know anybody who's using the protein subunit vaccine clinically, even though there's one that's available. And maybe that'll kind of pan out at some future point, but to my understanding, that's not certainly the common one. And what you really need to think of is the monovalent versus the bivalent. So the monovalent is the typical product that we start with for folks who haven't been vaccinated, and the bivalent typically has been used as a booster dose after folks have gotten the monovalent as their first shot. And there's sort of here's some criteria for pediatrics. So here, this table includes all those guidelines in pediatrics. This next table looks at patients over the age of 18. And again, we look at the initial doses of the mRNA vaccine, which is the primary one we see used, as the monovalent, and then the bivalent used as the booster doses. And so that's pretty sort of common, and encourage folks to really do that. There's also guidelines about who's a candidate for when they are and how they are, based on when their last booster was or dose was of the vaccine, which vaccine maybe they got, and whether or not they had COVID. So typically, the COVID issue in the last has evolved to say that if you've had the latest recommendation as of October 2022 is if you've had COVID in the prior 3 months, wait till you've received, don't wait for your booster until you have been 3 months after COVID, because if you've had COVID, you're probably reasonably protected and you want to sort of get the best bang for your buck. The last sort of thing here with the COVID looks at the products that are available. And typically, the big issues that I think we see primarily are the monovalent versus the bivalent, and Pfizer versus the Moderna versus product. Those are the mainstay of product. There are a couple other products as well. Most individuals have pretty much abandoned the Janssen or the Johnson & Johnson product, which had some concerns with increased risk for thromboembolic events in a small subset of patients, and maybe not quite as effective the way it was sort of done as a single dose initially. But all of this sort of evolved. And I think the other issue you want to think of is that when there is a new product like the bivalent as of October 2022, well, it may not have full FDA approval, but it has close to full FDA approval, and they go through an emergency protocol to allow it to be put on the market. So I think you really want to be up to date on what's happening with COVID vaccine sequencing, and what's the latest. As COVID evolves, expect to see that the vaccines will evolve as well. One of the last areas we're going to talk about is monkeypox, and monkeypox is particularly problematic. Monkeypox related to smallpox, and problematic in individuals who have a lot of contact exposure. This is seen, the majority of folks in the United States who've had monkeypox exposures have been men who have sex with men, but it's not limited to that. It is really a contact concern. The interim guidelines look at the use of a specific vaccine for monkeypox, the Jynneos vaccines. And the summary, I'd encourage you to go to the CDC's website to look at the vaccines that are used here. The primary vaccine, the Jynneos vaccine, is a 2-dose series, 4 weeks apart. There's criteria for who are candidates and who aren't because it's a limited supply. They look at preserving this vaccine, and so they're recommending, as of October 2022, of using an alternative intradermal regimen that uses only 1/5 of the dose, and so they can preserve the supply, and it still works reasonably well. At the bottom of this slide, you'll see that. And the intradermal, not very many vaccines are given intradermally, but if you go to the CDC's website and the list here, they'll give you instructions on how that's done. As an alternative to that vaccine, they also will, the CDC has recognized that there may be a role, particularly if you can't get that vaccine, to look at the smallpox vaccine. And so the criteria listed here is an alternative to consider as well. I think that this is not considered the first choice, but is a consideration for folks who are at higher risk if there is no supply available. Okay. All right, so we haven't covered all the vaccines, but when you think about vaccines, there's a lot of things that you want to consider in practice. You want to consider, you know, the shared decision-making process that happens between you and the patient who's going to be vaccinated, or you and the parent or guardian of the patient who's going to be vaccinated. And that process might not be done on one visit, but the determination of where people sit in vaccines certainly has been colored by our social media and by political and other concerns that are sometimes conspiracy based. And it's concerning to kind of convince people the risks and the benefits. What's particularly difficult, I think, for those of us who have been in healthcare for a while and seen these vaccine preventable illnesses, the weighing the risk and the benefit of vaccine or not is just so obvious to so many of us who have seen these vaccine preventable diseases, have seen how well tolerated these vaccines are, uh, and then to see people, just blatantly make statements that are range from inappropriate or inaccurate to frankly, lies, just no truth. It's really frustrating because we see the healthcare outcomes that these have, but you have to kind of realize that patients have to come to that decision themselves, and that we can't necessarily force vaccination on them. Um, Although there are circumstances where there are consequences for not being vaccinated. Uh, and let patients come to their awareness. So sometimes this has, multiple office visits. We sometimes try, many times where most clinicians, their best approach is to start being very just matter of fact about things. And not get in arguments, because an argument is going to paint a patient into a corner that is going to then make them more resistant to vaccination. But sometimes storytelling or sharing experiences of what they've seen, patients often have difficulty understanding risk or assessing risk, or are confounded by that. But a story or a couple of stories or experiences you can share professionally that sometimes can convince folks. You don't want to sort of, go down the argument of you're being a bad parent because you're not vaccinating your child. That argument doesn't work. It just makes everybody feel bad, and it won't change decisions. So you really want to kind of walk through this. I'd encourage you to talk with your colleagues, talk with your classmates uh, about what it is that vaccine hesitancy for folks who have it, and what can help them circumvent that. And sometimes nothing will circumvent it, but it's a sad state of situation when we've seen as clinicians this vary over time. Okay, very good. Any questions? Please bring them to class with you.